overview. How did we get to this course topic tonight? Well, if you haven't had the chance, in August of 2013, the American Dental Association put out a paper called A Profession in Transition. It's really a great read, 25 bullet points sort of talking about some of the issues that are going on in America today with insurance and how the erosion of dental benefits, patients making choices based on what their coverage can do, the dental schools, how they're increasing, how students are coming out with larger debts, et cetera, et cetera. It also focuses on some of the procedures, and what we do know, and I'm not sure if this is globally the statistic, but I would bet it's pretty close, that 40% of dental revenues in an office are Crown and Bridge, 80% of which are single unit. And so when you're taking those things into account, any little tip or trick to be more efficient and better at your craft, I think is something that we all want to learn. Well, a little bit about philosophy. I just want to share a few points because I think it's part of what we all need to do on a day-to-day basis, no matter where we're working or what country. And this is a buzzword that you've probably heard, comprehensive dentistry, and my definition of it might be slightly different, and I believe it's the ability to recognize and provide as little or as much dentistry required to meet patient needs. The complete dentist knows how to offer a little or a lot of care with equal grace and skill. And really what it's about is putting the patient in the center of what our treatment planning is, and that's where you're going to stay safe and you're going to do really, I think, the best kind of care. But how do you get there? Well, you have to have a core philosophy. For me, it's about treating people first, but teeth are a really close second. Sometimes it would be really easy for us to just have the patients drop their teeth off, let us work on it. I mean, when I was in school, the dentistry was a challenge. Now, I think we'd all agree, the dentistry is what's easy. It's management of the people that are attached to those teeth that becomes the challenge. Also, we need to seek first to understand rather than to be understood. The Chinese have a beautiful proverb which states that we're born with 2 ears and 1 mouth. You're to listen twice as much as you are to speak. If I put it in even more practical terms, as a boy, when I was being called out by my mother, and most mothers call you out by your full name, Timothy Michael, she would say, and it was either I was in trouble or there was a teaching moment about to happen. In this case, it was the latter. She'd say, Timothy Michael, you never learn anything when you're talking. And there's a lot of truth to that. So sometimes if we let the patients talk, they're going to lead us to the answer if we just allow them the opportunity. From a patient's perspective, they're really only looking at it from one of 3 ways. They just care if it looks good, if it feels good, and if it's going to last a long time. I know that it was fun in dental school, at least for me, to go into a pub or whatnot and, you know, say words like armamentarium or iatrogenic and have a laugh with your friends. But if you use those big words with patients, obviously they're not going to be too impressed. And I read somewhere where most Americans read at or below 7th grade reading comprehension. So we really need to use small language that's clear and concise whenever we're explaining treatment to the patients. And Will Rogers, who was a great comedian, he really summed it up best when he said, when I go fishing, I don't bait the hook with something that I like to eat. And really, we all could learn something from that bit of wisdom. Now, I cut out, this was an interesting article that I had read that was in Dental Economics here over in the States. And basically, what it said was that if you're going to get patients to continue to frequent your business and come back, they're looking for a few things. First, treat the patient, not just the tooth, which is sort of what speaks to the core philosophy that I stated earlier. Second, perio charting. Third is co-diagnosis. Patients are all about you reporting findings nowadays. The days of doctor knows best, especially with the institution of Google, where they can pretty much look up any procedure and sort of what people have commented, I went through this, etc. They really want you to kind of take them on a tour of their mouth and kind of help them find the problems and also the ways to fix them. Time, pain, and money, and it's in that order. Patients really want to know, what's the time involvement? Is this going to hurt? and what's it going to cost. And really, money does come last in this case. Last is regeneration as a differentiator. Harvard Business Review put it like this: the businesses that continue to grow, the ones that continue to get frequent in and get rave reviews from their customers, are those businesses that continue to show and strive in ways to create or add new technologies and new procedures or new ways of doing things or ways to simplify. So when we take a look at dentistry, this really helps us to stay cutting edge in ways that we're going to continue to get patients frequenting our practices. Now, when it comes to creating the optimal tooth preparation, there's things that we need to keep in mind, pearls that we need to remember from our days of being in dental school, and how we can take it into a real private practice setting. So, if we look at the Leaning Tower of Pisa and we see that as they continue to lean toward each other, when it comes to crown preparations, what really is the appropriate angle that we need to form between two opposing walls? And historically, if we look back to the text in the prosthetics, you'll see that it was ranging from 2 to 5 degrees, so very straight wall preparations to be able to get a really good convergence angle. But when we look at what really causes crowns to dislodge, we need to start thinking differently. What really does cause crowns to come out and dislodge are resistance form to lateral forces. This is the determining factor. So what causes crowns to come out in the first place are lateral forces. It's not the pulling. It's really when the patient is going into those working movements in lateral excursions. So our preparation becomes key when it comes to these movements. In textbooks, you'll see that modern-day Schillingberg in 1997 is going to say that your overall occlusal convergence can be as low as 10 degrees on anterior teeth and as high as 22 degrees on molars. So the text is beginning to change and see that, you know what, 2 to 5 degrees is a bit stringent. We can actually get away with a little different, a little more variance. 10 to 22 is going to keep a crown on and resist those lateral forces appropriately, especially with modern-day cements. We also have to keep in mind that when we are prepping, mandibular teeth tend to have greater convergence than maxillaries. It might have to do with the position of the patient. Typically, we lay a patient back, perpendicular or parallel, to the ground when prepping maxillary teeth, whereas we have a more upright and seated position for mandibular, so we tend to get greater convergence on mandibular teeth than maxillary. Also, we tend to have those mesial and distal walls converge greater on molars than we do on our premolars or anterior teeth. And I really do think that has to do with access. Access, of course, is the key determinant in these things. It's harder to work on a second molar than it is to work on an anterior. And everyone, I would assume, would agree with that statement. So when we're looking at convergence angles of those mesial and distal walls, you can see some x-rays of some preps, and you're looking at the convergence angle here, and what that's really going to help us determine is what kind of forces are going to be able to cause that crown to tip off or dislodge when the patient begins to move around. As we know, patients don't chew like alligators. They don't just chew straight up and down. They chew much more like a cow does, in that they have a teardrop pattern and shape of their jaw movement. It's not just a straight up and down, so we are getting those lateral forces affecting our crowns. So when we see a case like this come in, we have to start to ask ourselves the question of why might something like this dislodge, and it might not be the cement that we just purchased. Perhaps it's the preparation itself not being adequate to be able to resist those forces. Now, when I was in dental school, the teachers used to take pencils to be able to test my occlusal convergence on my preparations, and I call it the dreaded pencil test. But when you actually look at a pencil and its convergence, It's really closer to 17 degrees of convergence, which, if you remember from a few slides back, Schillingberg said 10 to 22 degrees is within the range of acceptability. So they weren't actually being that cruel. But when we're thinking about how can resistance form be increased when you find a prep, and I know that we all cut off old crowns, maybe it's our previous work or someone else's work that there's an issue. How do you correct that preparation and be able to get a good result in your final or new crown? And the answer is that if you pay attention closely to the cervical 1.5 millimeters axial wall preparation, if you can stand up that area without consideration of the rest of the prep, you're really going to do a dramatic increase to the retention of that crown. So when we take a look at a preparation like this, not too uncommon to see, it's a TP style prep where you have a excessive occlusal convergence. If you were to go ahead and focus your preparation design on standing up or correcting the cervical 1.5 millimeters to getting a preparation that looks more like this, you will have now solved the issue of the crown dislodging. And now the cement that you choose becomes more of a secondary thought than the determining factor on whether or not that crown is going to stay on better than the last one. So we also have to consider prep height. What's the appropriate prep height depending on where you're working? Well, the answer from the text is it's 3 millimeters on all teeth except molars. So from your cervical of your preparation to your occlusal, you want to have 3 millimeters, but if you are on molars, they're taking a more of the brunt of the chewing forces. You want to have 4 or more millimeters of tooth remaining. So these are the guidelines that are adequate, of course, only when your occlusal convergence is within that 10 to 22 degrees as stated in the text. So how do you go ahead and you measure that? Well, you got to get out a perio probe. Take a look at it, and you want to measure it from the bottom of your prep to the tallest, and you can see that in a preparation such as this molar here, you got 6 or 7, and that's pretty good for a molar. And then when you come into the proximal, though, when you're looking at these mesial and distal walls, you have less than 3. So you might have an issue, you might not. It really depends on your overall occlusal convergence and maybe the cement that you choose in this situation. Again, I do this on occasion. I take a look at some of mine, and you can see this one's just about 3, so technically on a molar, this shouldn't work. 3 millimeters isn't tall enough, and so there's things that we might need to do that at preparation to make it stand the test of time. So when we look at resistance to testing of uncemented crowns on dies, what's interesting is that with an occlusal convergence of 10 degrees, so something that's quite parallel, 3 millimeters is adequate for a molar. However, when you tend to go into the 20-degree range, it becomes grossly inadequate. And that's been tested many times over. And that means that in our molar preparations, we might need to do some different kinds of things. Again, with gingival aesthetics, we know that in the presence of some gingival margins, if you have a really good preparation, you're going to get good fit and contour, and everyone in the text agrees on these things. And that allows you to be able to take a case such as this, you get good working dies, good crowns, and you're able to take that to the mouth, and you're able to get a happy patient. This is the overall result that everybody's looking for in their practices, no matter where you are. You want to get this kind of finish form. And of course, this gentleman happens to have excellent gingival architecture, that thick and bulbous tissue, but well keratinized. And I mean, those are the kinds of cases that are just a dream to work in. So how do we capture sub-G? Well, we know historically we have the 2-chord technique. It's tried and true. We also have a 1-chord technique where you might pack it and leave in the sulcus during the impression. We have another version of that where you would remove it for the impression. And there's a bunch of money that's spent every year by companies in this category, hemostasis and vasoconstriction. Whether you have epi-impregnated cords or lasers or pastes or clays that you might use, or a product such as this, which are copper caps, which I just love using in crown and bridge situations. This is sort of big business because we know that blood and most impression materials don't work well together. So how we manage the tissue becomes a key in getting a good result for our lab technicians to make us a good crown. So running through the two-chord technique very easily, you can see a preparation here, and there is a 00 chord that is placed in the sulcus. That moves the gingiva out of the way about a 0.5 millimeter, and then you're able to place a top chord that's usually impregnated. I prefer to use an epi-impregnated chord, but some people use an alumina chloride. And that's left in for 2 to 5 minutes. It's pulled, and as you pull it, you're injecting your wash material as your assistant might be loading the tray, and that'll lead you to a great impression result from good technique, which will give you a great die for the lab to work on, and a great crown that can be fabricated. This is a Bruxer crown, which you can then take to the mouth, and you can see no tissue trauma and a good finished result. Now, there's a lot of debate on what you choose for your design of your margin. The chamfer is my preferred margin choice because it's very easy to form. It gives you a very distinct finish line and bulk and rigidity for crown preparations. And I know as a lab technician that if you give me as a lab tech a circumferential 1 millimeter circumferential chamfer margin, I can give you any restoration in dentistry today, and that includes a butt joint. So I like to keep it simple. I use the KISS principle and choose one burr to do my preparation. I don't use a block. I use one burr. My favorite burr is the 856-016. It's 0.8 millimeters at the tip. It's half of that second number here, so 016 divided by 2 is 0.8 at the tip, which I know if I get the entire tip into the tooth, I'm close to a millimeter, and if I do a little bit of refining, I know I'm there, and that can give me any restoration in dentistry, so I like to keep it simple. Because we're taught in school the different shoulder with a bevel versus a shoulder versus a chamfer. And, you might be wondering, well, why don't you choose this, or I was taught that. Well, if you go to the text and you actually look at what it says, Belser discovered that there's really no significant difference in marginal fit between any of these preparation designs. So when you look at that, you tend to if you might think like I do, like if there's no difference, I'm going to go with the one that works best in my hand. And if in your hand that's a shoulder preparation, I say go for it. And really, also Byrne in 1992 discovered finish line form does not significantly affect the fit of the cemented crown. So if fit's not affected and marginal fit isn't affected, choose one and try to stick with it. And I think for today's modern materials, I think the 1 millimeter circumferential chamfer works best for all the materials. When we look at reduction, 10 experienced dentists were taken and they were told to prep maxillary first molars on a tympanout. And what they found was there was a pronounced under-reduction in the central fossa. So they prepped okay everywhere, but when it came to the occlusal reduction, and this was more common with your metal to ceramic than your all-metal preparations, obviously because you need more room if you're doing a PFM or an EMAX type restoration as opposed to if you're doing a gold or an all-ceramic type of restoration. So What I suggest is that everybody go ahead and at times you want to reduce anatomically. I don't turn the burr sideways and just cut the occlusal off. I try to do it anatomically by using depth grooves, because the area that dentists leave short when you do that, laying the bird sideways and cutting straight across, is you'll get good reduction in the cusps, but not in the central groove, which can lead to problems and even fracture in these all ceramics like Emax crowns. So use a depth groove. It's going to help you stay consistent in your preparations, because you want to get this kind of result where you can see nice reduction and you're going to get nice uniform finish in your restoratives. Use of molar grooves, which interesting is they looked at preparations in a lab, and they found that out of 107 molars they looked at, only 8 of them had a groove when the die was evaluated. And yet 54%, more than half of the molars, had inadequate resistance to being tipped off the dies. In other words, the preparations were too short. In a molar, remember if you go back, 4 millimeters is the minimum height you need in the proximal. From here to here, the minimum that you're going to need is 4 millimeters. If you look at it from here to here, you're okay. But really where it matters for resistance is mesial distal. This one here is probably about 3. So you can see why 54% of molars are inadequate without the use. So if you're looking to increase resistance form, because you're not going to get a longer tooth and you don't want to drop your margins detrimentally sub G to get that extra tooth length, you're going to need to consider grooves or boxes. And the best place to go ahead and resist these dislodging forces from chewing, the lateral forces, is to go ahead and place your grooves in the mesial and distal location. So proximal grooves. I know dentists that say, but I like to place my groove in the buccal or the lingual. And they're going to help some, but what Woosley found out in '78 is that if you want to get the best resistance form by adding proximal grooves or boxes to your molar preps, you actually want to add them in the mesial and or distal location. And if you notice this preparation here, this is actually an Emax preparation. I'm sure people are sitting out there wondering, well, you can't do it for all ceramics. Yes, you can. If you notice, this is a very soft indentation. It's a hint. It's not sharp 90-degree angles like you would see in a GV black type preparation. We're talking at a very nice and smooth indentation. And your labs, if you make sure you tell them not to block these out, your Emax crowns will come back with just this little indentation, and you're going to get increased resistance form, and that's going to keep the cement from having to be the sole reason that your crowns stay on. So I am a big fan. I don't think I've prepped a molar in my private practice dentistry in 9 years without adding some sort of mesial or distal slot or groove, even in my all ceramics. So hopefully this is eye-opening to the group around the world. So when you're thinking of your tooth preparations in all ceramics, obviously there's guidelines that we all are familiar with. You want to have 2 millimeters of occlusal reduction. There you go, that 1 millimeter of axial reduction, circumferential, that's key. Nice to finish, well-defined finish lines. And you want to have everything rounded if possible to keep anything from being sharp or a chance where it could shear or cause porcelain fracture. And of course, rounded line angles. You can see this is what a preparation might look like in your practice on a molar. And 2 millimeters is adequate. I suggest everybody take a peek. One of the things I saw in the lab often that dentists don't do very well is take a second look to make sure that it's not tight. And if you reduce anatomically, you're going to see this much less, the lab calling and saying, let me send a reduction guide, or can we switch materials? Because you really do need to take a peek, especially through to the lingual side. The buccal you usually get excellent. It's this lingual cusp. I do it sometimes myself. It's just taking a quick second look before you take that impression. And that gives you the ability to make, dentistry look awesome. We have the best materials, I think, that have ever been available in dentistry to be able to give patients these kinds of results. So when we're thinking about crown teeth, we have to think about things in our practice. And obviously, we have to think about full fee versus insurance. I know what's happening around the country with the erosion of dental benefits and how some of the PPOs are charging very low fees, and that makes a big difference to the office profitability. And sometimes we have to also keep in mind at all times, due to these things, is our efficiency and our effectiveness and how we do things. And there's a saying that we had in the lab, and I share it with you. I skipped over it. It's garbage in and garbage out. So sometimes when we're getting in a hurry and we're not really taking and paying attention to detail, we might be sending out, and I know we are, inadequate impressions, and this really does have a big impact on what we're doing and what kind of final work we're getting to cement in the patient's mouth. Some things that, we just have to kind of remind ourselves is, hey, the assistant, number one way you're going to get a great impression is great tray selection. And I really put this on the assistants when I teach assistant courses. They need to get in the habit of trying these trays in, not just right before. They got to get the patient in, try it in, make adjustments as necessary, and then they got to paint the tray adhesive, and really it's a 10 to 15 minute reaction, and that tray adhesive is used to counteract shrinkage of the materials. All the materials we use shrink to some degree, and this tray adhesive not only holds it in, but it counteracts some of that shrinking. And I tell the assistant, saliva contamination, if you try this back into the mouth after you've applied the tray adhesive and saliva gets on it, it lowers the bond strengths by 80%. So it really has to be, try the tray in, make your adjustments, and when you know it's good, paint your tray adhesive on and allow it to sit for about 10 minutes on your counter so you're going to get a good bond. But this is the reality. A lot of companies may advertise a tray where you don't need to use tray adhesive, but I would recommend that you use it so you don't see this delamination, which really makes for an inadequate impression. It may be perfect for all other reasons, but now it's no good. Another source of impression distortion, I love the triple tray. It's such a great material to use because it takes the working, the non-working, and the bite all in one. They're very, very accurate to use in the lab. However, note, if you are prepping the most terminal tooth in the arch that happens to be in occlusion, you cannot use a triple tray. You have to use a full or quarter arch tray with a counter alginate model that's poured up and then a separate bite registration. The reason is, if you prep the most terminal tooth in the arch, when the patient closes, the back end of the tray flexes. Even in the metal ones, it's going to flex to some degree, which can lead to an open margin, high occlusion, or open contact, or a combination of all three. And none of them are good, and they're all sources of frustration in your crown seat appointments. So the question would be, would this be a good scenario, assuming that tooth number 2 has number 31 below it, and this tooth here, number 2, 3, 4, this is American nomenclature, of course, also has 29 opposing it, and I would say yes, it was designed to be able to take a first molar impression when the second molar is present, not being prepped, and is in occlusion with the opposing arch. So this is a great scenario to use a triple tray. You just can't use it in all scenarios. The reality is far different, though. We see this very commonly in the labs, and you may be saying, well, I don't get calls from my lab, and they don't send these cases back when I send this kind of work. And the reality is because they're in business, too, and they want your business, and they don't want to offend you. And so we would do our best to make this work and hope that you call this back with good report or no call at all, because the lab usually gets the calls that aren't good. But if you want to be kind to your lab today, if they're doing great work, do give them a call once in a while and tell them what's going right. It really makes their day, and they do note it. It makes them feel good. Now, when dental impression materials, there's a lot of things to cover, but I really want to focus in on what we're using for the crown and bridge, which are the addition silicones in most cases. Some of us might be using polyethers. When we think of a traditional addition silicone or PVS material, we know that if there's any fluid that's left in the sulcus, obviously these materials are innately hydrophobic, water-hating, and until the surfactants move towards the surface during setting, you're going to see this phenomenon where moisture is going to push away the impression material, and what that usually translates to in our impressions is either a bubble, a void, or a missed margin. Obviously, there are impression materials like Impergum, which is a polyether. This is the only innately hydrophilic impression material. It is a great material. It's fun to work with on some challenging cases, but it has its limits too, and we all agree that it's very stiff. You can see if you're not selecting the right case, you can do some of those iatrogenic dentistry, which is, I think, Greek for oops. But these are the kinds of things that can really mess up an afternoon where you pull the person's bridge off, and hopefully you didn't pull any core material off with it or whatnot. But this is one of the drawbacks. Great material, but it has to be certain cases that you use it to be able to get the right results. New category I want to discuss a little are these vinyl polyether siloxanes. And what they are the marriage of the two. We all would agree or should know that PVS materials have excellent dimensional stability, means they are very, very accurate on pour up and re-pour up. And polyethers are very hydrophilic, which is great because they work in a bloody or an oral fluid-filled environment, and that's great. So when you marry the two, you're getting the dimensional stability of PVS, and you're getting the hydrophilicity of the polyethers, and you get this new category. And Excellence, which is made by GC, is one such material. And what it does is, because it's water-loving, when you place it into a sulcus where moisture might be present, rather than you getting a void or it repelling or pushing away from your margin, it's going to adapt to your margin, and you're more likely to capture it even in the presence of blood or saliva or an inadequate moisture control. So that is something that's very nice, yet it has the dimensional stability of your standard PVS materials. It has been reported in the journal Prosthodontics that 89% of impressions had one or more observable errors. And really, when you take a look at them, here's a void. And you can look at the cast of characters here. You can see air bubbles in materials. These are all leading to maybe violations of working time. It could be to not removing the fluids. I mean, there's a host of things that can go wrong. This is a delamination where the working time is violated between the tray and the wash, and now they don't get that good bond between it. And you may send this out, but really it leads to a very inaccurate pour-up. What we're looking to do is get good marrying of the wash and the tray material, good retraction of your margins, and actually capturing beyond the margin, if possible, down on the root surfaces, so that I get this. I mean, I'm saying, wow, this is somebody who takes their time to really capture impressions, and I'm going to go ahead and I'm going to put that in my best tech's hands when I'm working in the lab, or keep it for myself, because I got to tell you, these are the pleasure cases to work on, and what we should be striving for is to do this in these cases. But I obviously know it's tough. You've got to remember, I work as a dentist too, and sometimes when you're wrestling with that cow tongue patient, or somebody who's that gagger and all these different things, we can't get these things reliably, and so that's where using some great materials really, really does help. And obviously we have choices today between, do we go with metal or ceramics or PFMs, and what are the choices? And really it comes down to the prep designs. Outlined in red here is what you would see for a full gold. Black would be PFM, and the blue here is all ceramic preparations. And you can note the difference in tooth reduction. Obviously, in order to get certain properties and physical properties out of these modern-day materials, you have to remove more tooth structure, and those are judgment calls that we have to make based on the patient's request as well as what we feel is going to be best for the long term. You can see here the two highlighted in red are really where the market is shifting towards. These Bruxer or full zirconia, monolithic crowns, lithium disilicates, where you're having one-piece material basically giving you the option to use one that's very high strength, and lithium disilicate is also high strength. It's also very aesthetic. But there's a lot of choices out there, and I've used several of these materials, and I see a lot of good out of all of them. An interesting category is this resin nanoceramic. I've done some beautiful restorations. So really we have a myriad of choices here as dentists. And I think if we simplify the process with our preparation designs, keep all of them in play, it really does make it for an easier day at the office. So when we're thinking about cementing, there's some things we need to consider. And obviously, working with my dad, he's been a big fan of zinc phosphate. He used it for years, and I have no problems with it. Obviously, it works. It still works. I think it's still applicable for certain situations. And you know, it's wonderful stuff. I've seen crowns that have been on of his for 35 years. They don't have decay under them. It's amazing stuff. So really good material. And of course we have the glass ionomer cements, which tout, you know, fluoride release. And we have the self-adhesive resins, which really are a nice bridge between conventional cements and our resin cements with separate dentin bonding agents, which I pretty much reserve this class and category for when I'm cementing veneers. Otherwise, I try to really keep it simplified and use either a self-adhesive or some form of a conventional cement with my traditional crowns. So when I look at this, these are two preparations for EMAX. You know, how many dentin tubules are there? Well, there's probably about 3 million in this picture, and I would never in a million years with all that dentin put a etchant on these to get bonding. I try to use something that's going to keep the smear layer intact. If I feel like I need a resin, I'm going to go with something that's self-etch, or I'm going to try to stick to conventional, because I know that if I don't seal all those little tubules, I'm definitely going to have sensitivity and perhaps an unhappy patient. I'm big into disinfection. I recommend it whenever I have my patients back. You know that smell that usually is underneath our temporaries. It can be even unpleasant for the patient. Temporaries do leak. Even the best of us that do our best to seal those margins, they do leak, and the smell's there. A couple choices are Gluma, which also has a little disinfection when you apply it in a couple applications. The drawback, and something they have to keep in mind, is that if you do get it on the patient's tissue, it may cause aphthous ulcers. Keep that in mind. And then 2% chlorhexidine is my big fan. It doesn't taste pleasant if the patient gets it on their tongue, but it gives you substantivity. At a 2% solution, it sticks around 24 hours, killing bugs off, and it's just a real feel-good for the patient. We say, hey, I'm disinfecting your tooth. I dry it off a little bit with air to evaporate, and then I bring the loaded crown with cement in, and you get really nice results and virtually no sensitivity using that method. So for crown seats, in my office, they're usually 20-minute procedures. I go ahead, I remove the temp. I have my assistant clean the preparation off, try in the crown, check the margins, and check the contacts, and make sure everything looks good. On occasion, you might take a bite wing to see if the margins are open. That's really a personal preference. Legally, I have to cement the crown, but the assistants can do the disinfection, and they can review post-op care, which is really important with our patients. So we're looking at choices today, and if I'm a patient, I'm going to be choosing the one on the left here. I want to have tooth colored if possible, and we all hopefully use these materials, and I can see why. They're advertising directly to the patients. But the question becomes, how do you treat this surface? Because we're becoming very aware now that the internal surface of zirconia crowns, BruxZir crowns, full contoured zirconia crowns, they're very susceptible to salivary ions. So what the manufacturers are telling us is if you've done a try-in, like most of us do before cementing, and saliva gets into contact, you need to use a paste to clean the material off and remove the salivary phosphates. Apply a zirconia primer, and now you can go ahead and use any of your cements. Another method would be, if you can remember right out of the box before trying it in, you could also do a primer, and what it'll do is it'll seal that surface and protect it from saliva ions. And then after you've done your try-in, all you have to do is simply rinse the inside out if necessary, apply your cement, and you can go ahead and use your cement of choice. Using or talking about cements, one of the great things about using a cement like this is it's a bridge cement. It's a self-etch resin, but it also has some nice features to it, which is that it's got a great self-cure mode, but it bonds very well to zirconia in one step because it has a proprietary phosphate monomer, and really it has good color stability, wear resistance, all the things that you would expect out of a GC cement. And you can see some of the bond strengths as they're adhering. It increases in strength over time, particularly over the first 20 minutes or so in both Denton and self-cure mode. So it's really a wonderful cement. Now, when you're thinking about zirconia, something you have to keep in mind is that you are not able to etch with hydrofluoric acid. You cannot etch zirconia. Zirconia is a metal. It's actually on the periodic table of elements on the metal side. You're unable to do it. Best way I have found in talking to the experts is that if you can, you want to micro etch it if possible. You would want to sandblast with alumina oxide the internal surfaces of your zirconia crowns if possible. Again, here you go, showing that using a material like this, it's one step. You don't have to apply separate primers if necessary. So you can go ahead and you can take your zirconia crown, you can take it out of the box, you can try it in, and after you clean it out on the inside, you can apply the cement and you're ready to cement. You can skip some of those materials that are quite expensive as you begin to reorder them several times. When you're looking at lithium disilicate, where somebody might be using this is also very strong bond strengths to lithium disilicate, and you can see it's upwards of 30 to 40 megapascals. And lithium disilicate is a ceramic, so it is etchable. So when you're looking at prepared teeth, typically the lab will do a hydrofluoric acid treatment of your lithium disilicate when you indicate you will be doing bonding for them, but if you're doing it yourself, you apply it. It varies based on the hydrofluoric acid you use, maybe 30 seconds. You might apply a silane primer, and then you would dispense your GSEM linkase into the crown, seed it, tack cure the margins, flake away the excess, and then allow your 3-minute dark cure, or have your assistant also then finish the cure with the light, is what I like to do. So let me show you a little case demonstrating some of these principles. This is Allie, and Allie came to me looking like this and said, hey, I'm getting married and I don't want my wedding photos to look like this. When are you getting married, Allie? 2 weeks. So obviously I only have 2 weeks to do a great turnaround, so what I decided to do is the next best alternative was make her some really awesome temporary. So I ordered her some Biotemps, I prepped her up, this is what she left looking like for her wedding. She got great wedding photos, she told me, and she was real happy, but she disappeared for about 9 months. And then she came back finally, and the tissue was looking pretty raw, and she had some other issues going on, and she wanted to finish the work. So I went ahead, and this is what the tissue looked like after 9 months of wearing a temporary. Obviously, she's not cleaning very well in the proximal because they're splinted together. But I did what I could. I cleaned up the preparations. I packed cord. I did the best that I could, and you can see it's still a bloody mess in there. And we were working on a limited time frame, and she was moving, so I had to get the impression that day. So I chose a material that was going to be more forgiving in this case, because this was what you see in private practice. It's not always ideal. So I went ahead and I chose GC's Excellence, which is a vinyl polyether siloxane, because I wanted to have the dimensional stability, but the forgiveness of a material that could work in this bloody environment. And I captured the impression. I zoom in here, and you can see, you know, it's nice to have a material working on your side. I know there's a lot of great impression materials out there, but I needed to use something that would give me a little more forgiveness and make sure that I only had to do this one time. I made some refinements to her temporaries, opening up the proximals, and I put her on some special rinses, and there's really some fabulous rinses that are out there right now. And sent her away. She came back. That was 2 weeks later. You can see a marked difference. And I was really excited about that because the cementation was going to be a lot simpler. And this is the dyes coming back from the lab. You can see I practiced what I preach: circumferential, 360-degree 1 millimeter chamfers. I chose lithium disilicate in this case, and I decided that I was going to bond these in using GSEM linkase. But again, I was not going to flirt with the tissue. So what's beautiful about using this kind of, as I call, a bridge between conventional and resins, I didn't have to do any etching. It's all self-etch. I just basically squirted the cement into the lithium disilicate. They were already silinated and pre-treated by my lab, and went ahead, cleaned it up, and she was really ecstatic. And I, of course, was ecstatic because seating 6 of those took about 35 minutes with numbing the patient, and that is a good morning when you have a day like that. Of course, I did, before I finished her up, a couple teeth went necrotic, and I went ahead and I finished those endos before I cemented the crowns. That way I didn't have to cut holes through my nice brand new Emax crowns, and I had great access at that point. Just to close, I think there's 3 methods for learning wisdom according to Confucius, and I'll share them with you. The first method is by reflection, which is noblest. I mean, if you want to study happiness, read books about happiness, you're gonna learn about it. You want to become richer, read books on finances. That's what Confucius is saying. He's saying reflect. This is noble. Pick up a book, learn something. He says, second, it's by imitation, which is easiest. If there's something you see somebody doing and you want to do it, copy them. Ask them how they did it. Follow what they're doing and see if it works for you. Imitation is the easiest way to gain wisdom. But Dennis' favorite way is the third one, which is by experience, which is bitterest. At some point in my career, when I've amassed enough, I'll give a lecture called Everything I Did Wrong in Dentistry. Because, I mean, we all have skeletons in our closet, but really that's where we really and truly learn from one another, is when we share some of those flaws, the things that didn't go well, the implant I put in crooked, the post that I perforated out the tooth, and learning how do you rebound from those things. And hopefully tonight you were able to gather some information that you're able to take back to your offices tomorrow on Crown and Bridge, kind of start to finish, change some of those preparations. And this is some contact information about where I can be found.